affected Egyptians are children. These are two studies from Upper and Lower Egypt revealing the prevalence of HCV antibody in children to be 3% and 9%. And Dr. Gohari, she was the chairperson of the last session. She studied and reported an incidence of 70% in hemodialysis patients, 7.7 in healthcare workers, so everybody has to take care, and 75% in thalassemics. And another study group studied the prevalence of hepatitis C antibody seropositivity in 4 high-risk groups, and they had a 12% incidence in normal children. So this is the conclusion, that we have the highest incidence, we know that, and the 12% in normal Egyptian children. When we come to the liver affection in thalassemia, chronic liver disease in polytransfused thalassemics is an important cause of morbidity and mortality, and it's usually due to hemosiderosis and virus infection together. But the role of undiscovered transmissible agents cannot be excluded. 30 years ago, did not know anything about hepatitis C. Maybe after 30 years, there will be another transmissible agent that we don't know of currently. Hepatitis is present even in 30% of thalassemic patients with normal enzymes, and in 57% of patients with enzymes only twice the normal range. Increased iron stores have been suggested to be an important factor, and even the thalassemics have a mild liver necroinflammation, whether the HCV is present or not, and the significant fibrosis can be attributable also to both erythrocyte catabolism and iron hyperabsorption. Even in anti-hepatitis C virus negative patients, the liver is affected in thalassemics, and the abnormal liver functions is more than 1/3 of thalassemics is present. When we come to the risk of acquiring hepatitis C through transfusion, the literature has agreed that the estimated risk of acquiring HCV infection is surprisingly higher than the generally accepted estimated risk. But other routes of transmission may be important. We all know at the hematology clinic these dates when we started to vaccinate our patients in 1992, and then in 1993 it became mandatory all over Egypt. All newborn infants are vaccinated against hepatitis B, and this was actually the result that the incidence of hepatitis B infection has reduced so much in thalassemics. Screening for HCV has started in 1993, screening for HIV in 1994, and in 2001 we started screening for HIV antigen and antibodies. I will go through some studies, the early studies in 1993 of Professor Bishlawi studying the profiles of hepatitis B and C in multi-transfused children, and the incidence of hepatitis C antibodies was 86%. And when we compared this to an earlier study done by Professor Abul Hassan in 1989, we found that the incidence of free patients has increased from 2.6% to 7%. The hepatitis B virus was almost the same, and the hepatitis C virus has shown in 1993. This is also an old slide from an old presentation showing the decrease in the incidence of hepatitis B markers after the vaccination, but the incidence of hepatitis C antibody remained quite the same. This is a study by Dr. Razi, which is a colleague at the hepatology department, and she studied 105 Egyptian pediatric patients with positive HCV, and 83% of them had HCV RNA positive cases, and this was present history of blood and or blood products transfusion in most of the patients. This is another study by Professor Bishlawi, and this is another one studying 389 patients in 2003, and the incidence was still around the 74%. In 2004, 440 patients showed an incidence of 65.7%. And this was another study published at the International Journal of Laboratory Hematology in 2009, where we studied 101 antibody-positive patients. 64 of them were positive by PCR. Liver biopsy was done for 22 patients, and I don't want to go through all the results, but the liver biopsy showed the activity stages and fibrosis stages, and there is a correlation between the enzymes and ferritin in positive cases and the enzyme and ferritin in HCV antibody positive cases. And the recommendation of this study was it is very cost-effective to test blood donors by PCR, and it is mandatory, and it is cheaper when we start treating patients for the HCV. This is another study published in the Asian Journal of Transfusion Medicine, blood transfusion among thalassemia patients at our center, and this was 464 patients with thalassemia major. The details of the study showing the serum ferritin level, the type of chelation therapy, the hepatitis markers for both hepatitis B and hepatitis C were 87% had hepatitis C. This is the prevalence of only the green one. The green one is hepatitis C only. The red one is the hepatitis B virus only. And here, the 18% represent both patients with positive for hepatitis B and C, and 29% negative for both hepatitis B and C virus. These are the clinical data of the groups. The number of patients positive for hepatitis C were 69%. This is the correlation coefficient of the lab data and the liver iron concentration. This was the conclusion of the study that hepatic iron overload has a potentiating effect on hepatic fibrogenesis in hepatitis C positive and negative thalassemics, while the effect of hepatitis was of no significance. So this is the conclusion of all the studies, that hepatic dysfunction is still frequent in multi-transfused patients. The role of undiscovered agents cannot be excluded. Despite screening of blood for hepatitis B surface antigen, thalassemics were still susceptible to the hepatitis B infection, and it was the routine vaccination that prevented the emergence of new cases. The seroprevalence among multi-transfused Egyptian patients is comparable to many other countries. This is the case in Italy, in Libya, in all the Mediterranean countries, in Cyprus. Surprisingly, in Lebanon, the case is different. They have a low incidence of hepatitis C, and this must have a genetic factor. HCV infection is the most prevalent transfusion-transmitted infection and remains a major health problem for these patients. We have to implement measures like donor education programs, standards for donor selection, improved serological screening, and so on, in order to prevent the acquisition of hepatitis C from the repeated blood transfusion. Lastly, I will focus only on the intrafamilial transmission of hepatitis C, and this was a study of a cohort of more than 6,000 Egyptians from two rural areas. Asymptomatic anti-hepatitis C seroconversion occurred in 33 people. They studied the people and followed them up. 28 in the Nile Delta village with a prevalence of 24%, and 5 in the Upper Egypt village. The stronger predictor was an anti-hepatitis C virus positive family member. The incidence was 5.8 per 1,000, and 27 of the 33 incident cases had an anti-hepatitis C positive family member, and 67% of seroconverters were younger than 20 years of age, and the highest incidence rate was in children younger than 10. And this shows the magnitude of the problem in the pediatric age in general. This is the last study we did, was about the intrafamilial transmission of hepatitis C infection infection multi-transfused thalassemia patients, published in the Journal of Tropical Pediatrics in March 2013. 137 patients and their family members were studied for HCV infection. We had an informed consent and approval of the Research Ethics Committee, and family members were asked to fill a questionnaire for the risk of hepatitis C virus infection. This was the method. We applied HCV antibody, HCV RNA, HCV genotyping to trace whether the virus was present in when more than one family member was affected, to trace whether it's the same virus in the same members. 34% were anti-hepatitis C virus and RNA positive. 24 families of the HCV positive thalassemics were screened. 45%, 45.8% were HCV. There was another affected family member. This creates a number of 11 families from the 24. While the 27 families with the negative cases, there were only 3 families having another family member affected, with an incidence of 11, percentage of 11. Seropositive prevalence of 19.2 among contacts of HCV positive patients versus 4.9 among contacts of seronegative cases. The prevalence of HCV positivity increased with the increase in the number of family members. The bigger the family, the more the incidence of infection. This shows the patients, and here is the number of HCV positive patients, and this is the number of HCV negative patients. 24 families screened, 73 members all over, 11 HCV positive families with 14 affected members, and the 27 screened families from the negative cases with a total of 90 members. Only 3 families had other affected 4 members in total. This is the prevalence among contacts of HCV positive and negative patients. We can see the marked difference. And this is the percentage of HCV affected family members. The brothers were mostly affected, then comes the mother, and then the sisters, and lastly the father. HCV genotype 4 and its subtypes were present in 100% of cases. HCV genotyping was similar in 87.4% of patients and their family members. 34% of multi-transfused thalassemics were positive, and in several Egyptian studies, the seropositivity was between 74% and 50%. This is similar. There are similar numbers in India. In India, the percentage is from 19 to 68%. In Pakistan, it's 42%. In Europe, it's 34%, and in Malaysian centers, it is 22%. Variability depends on two major factors: the prevalence of HCV in the relevant population, and the practice of HCV antibody screening before transfusion. The risk of post-transfusion transmission is 0.001% per unit blood transfused, and 1 per 100,000 in the US. There is a further decrease in Canada by application of nucleic acid amplification testing to reach 1 every 500,000 transfusion. The rates of infection in household contacts are higher than the infection rates in people who do not have household contacts. The HCV prevalence is from 2 to 10 times higher in family members. And intrafamilial transmission, we know all the reason why intrafamilial transmission occurs. It's because of inapparent percutaneous exposure, household items like razors, toothbrushes, and so on. But the high incidence in Egypt, many people suggest that there must be a sort of community spread that we don't know of. Because we can see people who did never receive a blood transfusion and never had an operation, and still they are testing positive for hepatitis C. This is very interesting that the incidence of transmission was more when the mother was affected than the father. So if the mother is affected, there is a greater instance that children will be affected. And also the brothers of HIV positive patients in the study families shows the highest rate of positivity among family members, maybe because they share the razors or shading materials or something. The prevalence of HIV positivity increased again with the increase in the number of the family members studied. With this, I conclude my study, raising just the attention that thalassemia is common in our country, hepatitis C is common in our country. We have to have measures for the prevention of thalassemia and prevention of hepatitis C. Thank you.
Thank you very much, Dr. Yanis, for this very introduction to the virus C. And I think you can recommend that every transfusion must be analyzed by PCR for virus C, because it is a common mistake appeared in our patients also. Thank you very much. And we can introduce Professor Mona Zaidi, Professor of Pediatric Hematology, Cairo University, and the subject is the target organ in Thalassemia, the Egyptian experience.
Thanks very much, Chairperson. I'm going today to talk about the heart, the target organ in thalassemia, and present some of our Egyptian experience. And I want first to stress that despite the long-term use of iron chelators and the overall improvement of survival of thalassemia major patients, still cardiac cirrhosis is the single most important cause of morbidity and mortality in these patients. And the persistently high mortality rate from heart failure indicate that the high-risk patients are not identified in time for the effective intervention. I want to stress about one very important factor in cardiac cirrhosis, that the left ventricular dysfunction and the heart failure in thalassemia patients occur later in the disease process, and when they are discovered, they are actually resistant to treatment. So, for a logic step towards an improvement of cardiac mortality is to optimize the early diagnosis of myocardial cirrhosis. Now, to revise quickly, the cardiac cirrhosis in our thalassemia patients, they will present clinically by heart failure, arrhythmias, pulmonary hypertension, myocarditis, and pericarditis. And the pathogenesis of this cardiac cirrhosis, of course, is mainly due to myocardial iron uptake, and either through the sarcolemmal or membranal endocrine calcium channel, or through the altered redox phenomenon. Iron overload will lead to the oxygen-free radical, increase in oxygen-free radicals that will either cause mitochondrial dysfunction that results in impaired cellular metabolism and impaired cellular energy production, or through the excessive cardiomyocyte loss of the apoptosis. The increased work burden of the cardiac muscle caused by the endothelial dysfunction is an important factor that adds to the cardiac cirrhosis. This endothelial dysfunction, as has been explained early in the morning is due to decreased nitric oxide production, whether due to decreased arginine, the precursor of nitric oxide, or the increased release of arginase enzyme, or due to the transfer of oxyhemoglobin to methemoglobin that will inactivate the carbon monoxide. The cardiac arrhythmias, whether the tachyarrhythmias are either due to change in the calcium homeostasis due to increased ratio of prostaglandin to prostacyclin, or due to excessive production of adipocyte that is responsible for tachyarrhythmias. Pericarditis and myocarditis are mainly due to increased viral infection susceptibility. What about the non-transfusion dependent thalassemia? Are they immune from cardiac cirrhosis? The answer is, of course, no. Although they are less affected, or the cardiac cirrhosis is less than the liver disease they usually experience, yet the iron accumulates through the increased intestinal absorption, and usually their cardiac tissue is damaged through the non-transferring bound iron. How to assess cardiac cirrhosis? Of course, traditionally, cardiac cirrhosis has been assessed through the time average serum ferritin, the liver iron concentration, echocardiography, the cardiomyocyte magnetic resonance, the radionuclide cardiac scan, non-transferring bound iron, and the B-type natriuretic peptide. However, what's very important, and I want to stress on today, is that the cardiomyocyte magnetic resonance is the gold standard of quantification of the myocardial iron load through the T2 star relaxation time, the left ventricular function, and also the endothelial function. However, what's very important is that we should put in mind that the left ventricular dysfunction, as measured by the ejection fraction percentage, identifies the patients at a late stage, and that also the left ventricular dysfunction is usually masked by the supernormal left ventricular function of the thalassemia patients, the chronically anemic patients. That's why several authors have insisted about this point. I think, for example, mentioned that the Anderson et al. In 2007 said that the male thalassemia left ventricular ejection fraction should be considered to be the least acceptable normal level is 59% versus the 55% of the healthy control, and the female thalassemia lowest acceptable left ventricular ejection fraction is 63% versus the 59% of the healthy control. Then what about the tissue Doppler echocardiography? The tissue Doppler echocardiography can be useful in assessment of the diastolic dysfunction. And actually, diastolic dysfunction comes at an earlier stage than left ventricular dysfunction. So the tissue Doppler echocardiography can be useful in assessment of the diastolic dysfunction by assessment of the E wave. The E wave is the peak flow velocity in the early diastole, or through the reversed EA ratio. The A ratio is the peak flow velocity in late diastole. The tissue Doppler echocardiography also can be very useful in determining the dilatation of the heart ventricles when the left ventricle and right ventricle and diastolic diameters can be found to be higher than the upper limits of the normal for patient's age. It can give us an idea about the dilatation of the heart chambers even before the left ventricular failure occurs. From the tissue Doppler also we can have a global systolic dysfunction when the fractional shortening is less than 25% and the ejection fraction is less than 55%. I'm now going to present you two studies carried out in the pediatric hematology department of our Cairo University. The first was on the low prevalence of cardiac cirrhosis in heavily iron-loaded Egyptian thalassemia major patients. The objective of this study was to find out the prevalence of cardiac cirrhosis among heavily iron-overloaded patients using the cardiomyocyte magnetic resonance T2 star relaxation time, and second, to relate these findings to liver iron concentration, serum ferritin, and left ventricular ejection fraction. 89 beta thalassemia major patients were recruited in this study. Their age ranging between 10 and 43 years. Cardiomyocyte magnetic resonance for evaluation of the T2 star and the left ventricular ejection fraction, and the ferri scan to detect the liver iron concentration and serum ferritin were done. The results of this study showed that 24.7 or 22 patients of the 89 patients, that represents 24.7% of the study population, showed the T2 star level below 20 milliseconds. In this group, from this table, we can see that the two groups were comparative on all the parameters except for the T2 star level, of course, and the serum ferritin, which was much higher in the group of patients with cardiac cirrhosis and cirrhosis. And I think it's very beneficial here to note that the left ventricular ejection fraction was comparable in the two groups of patients. The left ventricular ejection fraction is comparable in the two groups of patients, even it was higher in the group of patients with cardiac cirrhosis. This figure illustrates these same findings. And severe cardiac cirrhosis is considered when the T2 star is less than 10 milliseconds. It was present in 7.9% of the study groups, the mean age was 18.4 years. The mean T2 star was 7.8 milliseconds. The mean left ventricular fraction was 65.1%. Okay, and the liver iron concentration was, of course, very high, 29.8 milligram per gram dry liver weight, and the serum ferritin again was very high. And it was noticed that the T2 star is not correlated with all these parameters. It's not correlated to the age. It's not even correlated to the left ventricular ejection fraction. So myocardial cirrhosis in Egyptian thalassemia patients was detected in 24.7%, which is much lower than that reported by so many other studies. I chose three of them. The Tanner in 2006 said that myocardial cirrhosis in his study group was 65%. Dar in Oman in 2009 said it was found in 46%, and Button in 2010 found it in 64%. That means in our population, the myocardial cirrhosis was much lower. So, a potential genetic variation in function of the cardiac iron transport channels may be suspected. And since no correlation was found between the T2 star and age, the possibility of a genetic susceptibility of cardiac cirrhosis should be raised. And the relationship between, that is a very important point, that the relationship between T2 star and the cardiac function was found to be very shallow until a critical level is reached, after which rapid deterioration occurs. The other study I'm going to present it fast now is trying to search for a genetic background for the cardiac cirrhosis in our population. We studied the apolipoprotein E gene polymorphism as a risk factor of left ventricular dysfunction among our Egyptian beta thalassemia patients. Apolipoprotein is a lipid transporter protein that acts as a free radical scavenger. Its gene is located on the short arm of chromosome 1 of two alleles, E2, 3, and 4, and ApoE4 has the least antioxidant iron binding activity. The objective of our study was to investigate whether the different allelic gene types of ApoE could represent a genetic risk factor for the development of ventricular dysfunction in upper Egyptian beta thalassemia major patients or not. 50 beta thalassemia lesions more than 10 years in age on regular blood transfusion were included in the study ApoE gene and the echocardiography, actually tissue Doppler echocardiography done. Our patients were classified into group 1, comprising 9 patients. These 9 patients are totally asymptomatic patients with normal echocardiographic findings. Group 2 are again totally asymptomatic patients, but they show left ventricular dilatation on tissue Doppler echocardiography with no left ventricular dysfunction. And group 3 included 15 patients who showed symptoms that these patients were symptomatic and symptoms of heart failure, of course, with echo left ventricular dysfunction. The MRI findings of our patients, I'm going to run through. The T2 star ranged between 4.6 and 49, and the left ventricular ejection fraction ranged between 49 and 74%. This is a beneficial table because it showed a correlation between the cardiac T2 star and the echocardiographic findings, and it showed a positive, statistically positive correlation between the cardiac T2 star as measured by the magnetic resonance and the left ventricular end diastolic diameter, which denotes an early diastolic dysfunction. As regards the ApoE allele frequencies in our study cases, the E4, which is the least iron binding allele, was detected in 22% of our cases. This table again is a very important table because it shows a comparison between the ApoE cases and the non-ApoE cases. And it showed a very important highly statistically significant difference between the ApoE and the non-ApoE patients as regards the E and A waves. So, echocardiography was more sensitive in detecting the left ventricular dilatation in asymptomatic patients because it detected it in 52% of the study population, and the ApoE allele in the left ventricular failure group was detected in 20% of the study group, which is again different from other investigations done before. And the high frequency of the E4 allele in our population supports the theory of the oxygen-free radical contributing to the organ damage, and also we concluded that the ApoE allele can be used as a predictor of left ventricular failure, particularly in the asymptomatic patients. To conclude, I want to insist that the cardiac disease remains a major challenge in the management of thalassemia major patients, and the cardiomyocyte magnetic resonance T2 star though it's fast, robust, and very sensitive to, or the most sensitive to iron deposition, yet its availability and cost in developing countries should be considered. So, early detection of diastolic function before the frank left ventricular heart failure occur through tissue Doppler echocardiography is mandatory for the regular cardiac assessment and the follow-up of these patients. And thank you.
Thank you, Professor Mona, for your great presentation. Now, Professor Muhammad, University, so on renal tubular function and fibrosis. مش ناوي ان اخد الفرصه ان انا ابقى معاكم زي كل سنه ان شاء الله. والاخوه الاساتذه المنصه الاستاذه الدكتوره يسريه والاستاذ الدكتور حمدي الاصدقاء الاعزاء. والحقيقه انا عارف ان معظم الاتندي طبعا ناموا وجاعوا وحاجات كتيره. هحاول ان انا امشي بسرعه شويه. This is the renal tubular dysfunction in the children with hemoglobinopathies. As all of us know that the children with hemoglobinopathies are remarkably more prone than other to renal dysfunction. And the kidneys are a part of the systemic long-term hazard in children with hemoglobinopathies may be affected by both the hemodynamic changes of the chronic anemia as well as the consequences of disease and or the treatment of the disease. For example, the sickle cell disease. A wide spectrum of renal abnormalities are associated with sickle cell disease, including glomerular hyperfiltration, proteinuria, microalbuminuria, renal tubular dysfunction in the form of defect in urine concentrating ability, defect in proximal renal tubular deabsorption, and defect in the hydrogen ion and potassium excretion. And in the morning, all the lectures about the pathophysiology of sickle cell disease. In the early stages of sickle cell nephropathy, it results from the enhanced sickling in the hyperosmolar hypoxemic environment of the renal medulla with the decreased blood flow with the resultant ischemia in the vasa recta, microinfarcts, and the papillary necrosis. More recently, it has been noted that the number of mechanisms contribute to the complex pathophysiology of ACCD nephropathy with the dysfunction of the vascular endothelium as a common theme. In any chronic hemolysis or the hemolysis associated phenomena, there will be associated low arginine and low nitric oxide bioavailability, which is amplified by the superoxide production, the oxidative stress, the ischemia perfusion, reperfusion injury, and inflammation. All are the significant mechanisms contributing to this endothelial dysfunction. And on the other hand, the duration of the disease in these patients, the severity of this anemia, and other genetic factors are believed to influence the risk of developing renal disease among patients with sickle cell disease. And this is a very, very well-known phenomenon in sickle cell disease. But in beta thalassemia patients, although the prognosis of patients with this thalassemia has greatly improved in recent decades with the use of modern newborn screening, blood transfusion, iron chelation therapy. Yet, multi-organ dysfunction, cardiac, pulmonary, reticular endothelial, and the other major system dysfunction is still a problem. In contrast to the sickle cell disease, renal involvement in beta thalassemia has received little attention. The main underlying cause of renal tubular dysfunction in patients with beta thalassemia measured still unknown. But this damage to the kidney may be due to either the process of chronic anemia, the iron overload, the side effects of the iron chelators, or the three mechanisms. In the last years, we have conducted a number of studies aiming to investigate the renal tubular function in children with hemoglobinopathies. Two of these studies were multi-center and in collaboration with the Saudi centers. The first study was on the renal tubular function in patients with beta thalassemia major in Zagazig University hospitals. And the team of this work was Mohammed Badr, Taber Hassan, and Dr. Asma El-Hosh. And the subjects and methods, it was a cross-sectional study carried on 100 patients with beta thalassemia major in their regular follow-up visits to the hematology outpatient clinic at Zagazig University hospitals, and 30 age and 6 matched health controls during the period from January 2011 to December 2011. All these patients and the control were subjected to thorough medical clinical examination, routine workup for beta thalassemia patients according to our local standards, and collection of timed urine samples, 8-hour time urine sample for the determination of uric acid, creatinine, sodium, potassium, phosphorus, magnesium, albumin, and beta-2 microglobulin. And our results, in short, showed the renal tubular parameters in patients and in the control. And as regards all these parameters were related to the creatinine level. All the renal tubular parameters was related to the creatinine level. The uric acid over the creatinine level, the calcium, and etc. There was a significant increase of the uric acid, the calcium, the magnesium, the phosphorus, the sodium, the potassium, the albumin, and the beta microglobulin in patients with beta thalassemia major in relation to the control. We searched about the relation between these renal tubular parameters and the splenectomized and non-splenectomized patients. And as we see that the serum calcium, the phosphorus, and the magnesium were highly significant in relation it was very high in the splenectomized than the non-splenectomized patients. Also, the level of the albumin over the creatinine was highly significant in splenectomized patients than the non-splenectomized patients. This beta thalassemia measure was on dysferoxamine, difluropron, combination therapy, and dysferoxerox. And we searched about the relation between these renal tubular parameters and the chelation therapy. We didn't find any significant result between these renal tubular parameters and the type of the chelation therapy. The dysferoxerox patients was 7 patients only, so we can't detect any renal tubular abnormalities in dysferoxerox. In conclusion, in these beta thalassemia patients, periodic assessment of the renal tubular functions should be added to the routine workup for beta thalassemia major patients, and early detection of renal tubular abnormalities will allow specific measures to be undertaken that will delay the renal impairment progression and reduce its incidence. The other study about the renal tubular dysfunction in the children with sickle cell disease, and the team of this work was Dr. Muhammad Badr, Dr. Tamer Hassan, Dr. Muhammad Al-Komi, Dr. Yasser Ali, and Dr. Salah Al-Warshidi. And in this study was conducted in both the Gazebo University Hospital in Egypt and Al-Khafji Joint Operation Hospital in Saudi Arabia between the mid-2011 and 2012, and included two groups of patients, 34 children, 18 males and 16 females with sickle cell disease, and 27 children with sickle cell trait, 17 males and 18 females as a matched control group. All data, including the time of onset of anemia, frequency of blood transfusion, the complications related to sickle cell disease in the preceding 2 years were collected, and the urinary excretion of retinol binding protein and the beta-2 microglobulin were checked in both groups of disease. These are the demographic and the laboratory characteristics of the group of sickle cell disease and the sickle cell trait. As we see, there is a significant difference in serum ferritin of these patients with sickle cell disease, and the hemoglobin level is lower in sickle cell disease than sickle cell trait. The urinary osmolality is very lower, and the urinary beta-2 microglobulin and the urinary retinol binding protein were very much significant and higher in the group of sickle cell disease. These are the laboratory data according to the age. In our groups, we differentiate the age below 12 years and after 12 years to see the impact of the chronic disease on the kidney. And as we see in the serum creatinine and the renal osmolality, there is a big difference between the sickle cell disease group and the sickle cell trait. Also, in the urinary retinol binding protein, there is a great difference between the sickle cell group above 12 years and below 12 years in both groups. This is a correlation study between the retinol binding protein and the other parameters in the patients with sickle cell disease, and as we see, there is a significant, highly significant result between the retinol binding protein level and the increase in the urinary beta-2 microglobulin and in the serum creatinine level. So we conclude in this study elevated levels of retinol binding protein and the beta-2 microglobulin in the urine of patients with sickle cell disease indicate proximal tubular dysfunction. Also, beta-2 microglobulin is not stable in acid urines, and its excretion is particularly difficult to interpret without concomitant estimation of its blood level. We suggest that testing for urinary retinol binding protein may serve as a sensitive and early marker for the diagnosis and monitoring of patients at risk of developing renal tubular dysfunction. Also, and in addition, further multi-center prospective studies must be done on bigger numbers of children with sickle cell disease of different ethnic backgrounds at different points of diagnosis are necessary to establish the clinical utility of these urinary markers and to search about the renal complications in hemoglobin. Thank you.
Thank you very much, Dr. Muhammad Bas. And for the lack of time, I'm going to follow on the rest of the session. Now, the next speaker is the very professor of Anshams, Professor Dr. Hassan Abdelnawaz. Dr. Hassan Abdelnawaz is very much active in all aspects in pediatric hematology and infectious disease. I met her so much many times in international levels and national levels. Dr. Hassan is going to present microparticles, new link between mastropathy and coagulation disturbances in beta thalassemia patients.
Thank you very much, Professor Abshir. شرف ليا ان انا اكون موجوده في الانترناشونال ثلاسيميا داي. بسم الله الرحمن الرحيم. انا اشكر الاودينس عشان هم they are still waiting الحقيقه. It's too late. I'm going to speak about the microparticles. Microparticles have been described since 1967. They have been described as minute particulate form materials sedimented by high-speed centrifugation, originating from platelets but distinguishable from intact platelets, but they yet have coagulant activity. Since then, numerous studies have reported the in vitro release of vesicles from activated or apoptotic cells and their presence in the human plasma. Among these vesicles, they call them membrane vesicles, that are the microparticles. They are usually referred to as vesicles more than 100 nanometers in diameter, and they are derived from the plasma membrane, and they carry the data of the original cells. Smaller vesicles are 40 to 100 nanometers, are originating from endoplasmic membranes, are termed exosomes, and there are the apoptotic bodies, which are larger particles containing nuclear material, they result from apoptotic cells. Both the microparticles and the apoptotic bodies, they externalize the anionic phosphatidylserine, means they express phosphatidylserine on their outer surface, and this plays a crucial role in both activation of the coagulation cascade and in complement cascade and in initiation of inflammatory response. This shows the formation and the release of the microparticles, exosomes, and apoptotic bodies. When the cells are activated, it emerges from the outer surface of the cell, blabbing, and then shedding, and then detachment of what are called the microparticles. While during apoptosis, the shrinkage of the cell leads to the generation of what's called apoptotic bodies. Earlier, before the generation of the apoptotic bodies, there are the budding and the formation of microparticles. The exosomes, they derive from multivesicular body, and when this multivesicular body gets attached to the cell membrane and ruptures, we get these small particles called the exosomes. What we are going to speak about today are the microparticles. This is also how the microparticles are formed. There should be in the cell an increase in the ionic calcium, a change in the membrane phospholipid distribution, and a change in the musculoskeletal architecture of the cell. And then you get this, first you get a budding, and then you get a blab, and then you get the the microparticles. And simply by this budding, you get asymmetry of the cell membrane, and asymmetry of the cell membrane means activation of the cells. These are electron microscopy showing the microparticles. Why do cells release microparticles? The reason that cells shed microparticles from their main body may be an attempt to reverse the apoptotic process. The part which is shed contains unwanted signaling molecules, so they want to get rid of them. Perhaps it's also to escape phagocytosis. They remove quickly from the cell surface the eat-me signals, like the phosphatidylserine. And it may be some that this shedding could be a signal to the phagocytes, to neighboring cells, and so it helps to do communication between the cells. So this is the proposed model, the role of microparticles in health and disease. It has a role in health. The cells, they release microparticles to ensure homeostasis. They are important in the regulation of coagulation, inflammation, and endothelial function. But under conditions of stress, the cells, they are going to release microparticles. But the microparticles in this condition, they are different in the number, in the composition, and in the function. And they result in hypercoagulable state, pro-inflammatory state, and they result in endothelial dysfunction. So microparticles have a role in coagulation and anticoagulation. They have a role in communication between the cells, in the transport, in the waste management, in inflammation, in cell activation, in angiogenesis, and in endothelial dysfunction. Different types of cells, they produce microparticles, and every type of microparticles derived from certain cells contains or is expressing certain antigens. The most common are the platelets, endothelial cells, leukocytes, and erythrocytes, as well as monocyte granulocytes and the T lymphocytes. Most microparticles in the blood are derived from the platelets, whereas the microparticles from the erythrocytes, granulocytes, monocytes, lymphocytes, or endothelial cells are also present, although at very much lower numbers. This is a figure to show the cellular origin of circulating microparticles in different pathological states. The platelet microparticles have been reported with hypertension, myocardial infarction, diabetes, cancer, paroxysmal nocturnal hemoglobinuria, among others. Leukocyte microparticles have been described in type 2 diabetes, severe trauma, sepsis, HIV. Endothelial microparticles have been reported in acute coronary syndromes, type 1 diabetes, lupus, anticoagulants. You know, all of them, they have important roles in what's called vasculopathies. And the platelet microparticles, they have a role in vascular hyperreactivity, in hematopoietic stem cell proliferation, and in endothelial activation and angiogenesis. Endothelial microparticles have a role in angiogenesis, endothelial impairment, and the leukocyte microparticles also, they share in the endothelial impairment, endothelial stimulation, and vascular hyperreactivity. So if you are going to look, all the three types of the microparticles are concerned about causing endothelial dysregulation. And if we are concerning our pediatrics and pediatric hematology, we should speak about sickle cell disease, multiple origin. All types of microparticles have been described. In peripheral artery disease, mainly platelet microparticles. In embolism and thrombosis, mainly platelet and endothelial microparticles. And this is to show what has been explained in the morning, that in vitro studies, microparticles from various cellular or disease origins or both, means they could be red cell microparticles, could be platelet microparticles, could be endothelial microparticles. All of them, they cause endothelial dysfunction through the alteration of the nitrous oxide reactive oxygen species production. Microparticles are known to have their procoagulant phenotype by exposing phosphatidylserine, and recently reported by expressing tissue factor, which is an important initiation and factor for propagation of coagulation. They have been reported that for their procoagulant and pro-inflammatory properties, they have been reported to be associated with clinical cardiovascular disease. And it has been found that circulating microparticles are harmful, contributing to cardiovascular disease and their risk. Also, circulating microparticles of different cellular origins have been reported to be associated with subclinical atherosclerosis. In thalassemia, we know that cardiopulmonary disease is an important cause of morbidity and mortality related to iron overload, high output state, and vascular involvement, including increased pulmonary vascular resistance and increased systemic vascular stiffness. More than 4 years ago, we have published this paper about subclinical atherosclerosis in young beta thalassemia major patients, and we used the carotid intima thickness to evaluate subclinical atherosclerosis in addition to the atherogenic lipid profile. And so we are continuing by searching for the role of microparticles in relation to the hypercoagulable state and vascular complications of beta thalassemia major. And we have done this study. We have studied the platelet and erythrocyte microparticles in young children and adolescents with beta thalassemia major in relation to the echocardiographic features and aortic elastic properties in relation to the hypercoagulable vascular and hemolytic states. 60 patients with beta thalassemia major were studied compared to 40 healthy controls. The VA stressed on the clinical picture, coagulation, and hematological profile. And we have used different methods are used for evaluation of the platelet of the microparticles generally. We have used the flow cytometry, and we used for the platelet microparticles the anti-CD41B, and for erythrocyte microparticles the anti-glycophorin A antibodies. For cardiac assessment, we used aortic. We have evaluated echo Doppler for aortic stiffness, aortic distensibility, left ventricular function, and pulmonary artery pressure. The aortic stiffness describes the rigidity of the arterial wall. It's related to the pulsatile afterload presented to the left ventricle and is an independent predictor of cardiovascular morbidity and mortality. The aortic distensibility represents a decreased arterial compliance, is one of the earliest detectable manifestations of adverse structural and functional changes within the vessel wall, and is reported to be used for early detection of atherosclerosis. This is the flow cytometry for detection of platelet microparticles and red cell microparticles. And these are our results. In short, we found that the platelet microparticles and erythrocyte microparticles were significantly higher in splenectomized patients, in patients with a history of thrombosis, with a higher serum ferritin, and patients who were poorly compliant to chelation therapy, while the presence of viral hepatitis was not associated with a change. The echo Doppler findings revealed that the aortic stiffness index was significantly higher in beta thalassemia measured patients, and the aortic distensibility was significantly lower among the beta thalassemia patients, showing their increased risk of atherosclerosis even if asymptomatic. Other cardiac parameters we do know about these patients that they had lower EA index, they had lower aortic strain, ejection fraction was lower, fraction shortening, and the score of left ventricular end-diastolic diameter was higher in beta thalassemia patients. And the more important that 35% of our patients had tricuspid regurgitated jet velocity equal or more than 2.5 m per second, okay? And this means they were at high risk of pulmonary hypertension. When we examine the platelet and erythrocyte microparticles in relation to clinical characteristics, we found that risk of pulmonary hypertension was significantly associated with higher values of both microparticles. History of thrombosis was associated with higher values. Splenectomized patients had higher values. Serum ferritin had higher values of, was an important factor associated with higher values of microparticles, and compliance to chelation, while the same viral hepatitis was not an important factor. When we did multi-regression linear analysis of the relationship between microparticles and the different variables, I am going to report on what's left highly significant. For the platelet microparticles, there was significant value. One of the significant factors was serum ferritin and D-dimer reflecting activation of the coagulation cascade. While for erythroid microparticles, hemoglobin F, hemolysis, LDH, serum ferritin, and the D-dimer were important factors. I hope it's, as you see here, there is a positive significant correlation between the platelet microparticles and the erythrocyte microparticles, and the aortic stiffness index means they are closely related to vascular damage. And on the other hand, there was a significant negative correlation between platelet microparticles and erythrocyte microparticles and the aortic distensibility. So in conclusion, we can say that this study, this preliminary study, shows that increased platelet microparticles and erythrocyte microparticles may be implicated in vascular dysfunction, pulmonary hypertension, and aortic wall stiffness observed in thalassemia patients, increasing the risk of thrombotic events. Thus, their detection and quantification may provide utility for early detection of cardiovascular abnormalities and monitoring the biological efficacy of chelation therapy. Could be added to the serum ferritin, could be earlier marker than serum ferritin. I should thank my colleagues, Professor Amira Abdelmenaim from Pediatric Department, Professor Naveen Habib from Pediatric Cardiology Department, and Professor Iman Ismail from the Clinical Pathology Department. They did the major part of this work. I'm very grateful to them, and they made us able to publish in an interesting in a journal like the European Journal of Hematology. Thank you for that.
Thank you very much, Professor Asa, for this informative knowledge. And we can ask Professor Rania, Professor of Clinical Pathology from Cairo University. The subject is effect of circulating erythrocyte-derived microparticles and coagulation activation in sickle cell disease.
اولا سؤال الدكتور امين الشهوري على قبولي اني اكون احد المشاركين في انترناشونال ثلاثيميا داي. حقيقه انا دايما بكون من ضمن الحضور من سنين طويله عشان الدكتوره امين دايما بتتفضل بدعوتنا جميعا في اسم الهيماتولوجي كلينيكال باثولوجي المؤخر. Actually, I'm going to talk about the replacement erythrocyte derived microparticles on coagulation activation in sickle cell disease. I'm going to say it in a more simplified way after Dr. Hazard did the work. Sickle cell disease, the term sickle cell disease refers to a group of autosomal recessive disorders characterized by the presence of hemoglobin S variants of the beta gene, where the amino acid, the glutamic acid, is replaced by valine as the 6 amino acid along the beta-globin chain. 5% of the world population harbor alleles for hemoglobin, and around 100,000 children are born yearly in Africa with sickle cell disease, and the prevalence of hemoglobin S mutation is as high as 25 to 35%. But in Egypt, the sickle disease is not frequent except in the oasis, where the carrier rate varies from 9 to 22%. Sickle cell disease can present by many variants. It may present as sickle cell anemia, where the patient harbors both hemoglobin S variants and is homozygous hemoglobin S. It may present as sickle cell trait, where the patient is only heterozygous for hemoglobin S, or may present with double heterozygous for hemoglobin S and other abnormality as hemoglobin S and C, hemoglobin S, beta thalassemia, hereditary resistant fetal hemoglobin, or hemoglobin Z. According to the genotype of the patient, the disease severity varies. The most severe form is the homozygous hemoglobin S and the hemoglobin S beta 0 thalassemia. Less severe forms are hemoglobin S and C, hemoglobin S and alpha thalassemia, and hemoglobin S and hemoglobin Z. Some patients are presenting with only mild anemia and may be asymptomatic, as the patient with hemoglobin S trait, hemoglobin S and hemoglobin E, hemoglobin S beta plaque thalassemia, and hemoglobin S hereditary resistant fetal hemoglobin. I'm going to say a very brief introduction about the pathophysiology of sickle cell disease. The normal hemoglobin A gene is a tetravalent molecule. Composed of 2 alpha and 2 beta genes. The human beta gene carries epsilon, gamma A, gamma G, delta, and beta, and are located on chromosome number 11. While the alpha type globin gene are epsilon, are zeta 2, zeta 1, alpha 1, and alpha 2. The genes are present on both chromosomes in the same order in which they are expressed during development. In the sickle cell disease, the 6th amino acid of the beta globin gene is replaced. Instead of the normal glutamic acid, it is replaced by valine. The basic pathophysiology of sickle cell anemia is like that. Due to the abnormal replacement of the amino acid, the hemoglobin molecules adhere to each other to form a hemoglobin polymer, leading to the formation of the sticky-shaped cells and the known complications of sickle cell disease, which are the vaso-occlusion, ischemia, and the peripherasis. The mechanism of the polymer formation is as follows. In normal hemoglobin A, the oxyhemoglobin, the molecule is smooth from the outside, while in the deoxy form, it protrudes a notch forms in the hemoglobin molecule. In the abnormal hemoglobin S, in the oxyhemoglobin form, there is a protrusion in the one of the beta globin genes, and during the deoxy form, the molecule carries the normal notch and the protrusion. This leads to the adherence of adjacent hemoglobin molecules to each other, leading to the formation of filaments or polymers. So the normal hemoglobin exists as solitary units, whether oxygenated or deoxygenated, while sticky hemoglobin molecules adhere when they are deoxygenated, forming sticky hemoglobin polymers. This polymer formation occurs as a double mechanism. In the first stage, individual hemoglobin molecules have to come together to form a nucleus that will be the initiative point for the polymer formation. Around 7 homogeneous molecules are needed to come together to form this nucleus. And once the nucleus is formed, the second stage of the process begins, which is more rapid because the fibers build on the pre-existing structure. There are several membrane alterations in the red cell due to polymer formation. Once the polymer is formed, it leads to disruption of the cell membrane with opening of the calcium ion channels, leading to cellular dehydration and release of iron and heme from the cell, which produces oxidizing microenvironment and leads to more polymer formation. Also, it leads to disruption of the cell membrane with dislocation of oxidized serine phospholipids, and finally leads to microparticles release. Microparticles are a heterogeneous population of vesicles with a small diameter of 0.15 to 1 micrometer that are released by budding of the plasma membrane. They usually express antigens specific of the parent cells and can be generated from nearly every type of cell during activation, injury, or apoptosis. This is a simple diagram showing the formation of microparticles. When the cell is activated by agonist, this agonist results in disruption of the membrane skeleton, which is important for maintenance of the cellular integrity. Once the membrane is disrupted, it leads to the circulation of the small buds from the vesicle, from the cell. The other mechanism is apoptosis. Apoptotic inducers result in cellular contraction, and this contraction also results in disruption of the membrane skeleton with the release of microparticles. This diagram shows the cell membrane. In the normal cell membrane, the phospholipids, or the serine phospholipids, are located on the inner side of the cell membrane. Once hemoglobin polymers are formed, the configuration of the cell membrane changes, and in the other circle on the right, the oxidized serine phospholipids becomes located on the outer surface of the cell membrane. Microparticle actually has several biological effects. The most important we are talking about is effect in coagulation. It has a procoagulant activity through activation and adhesion of monocytes, activation and aggregation of platelets, cytokine production, and cell A2 production. It has anticoagulant function by inhibition of activated factor 5 and factor 8. Has fibrinolytic and proteolytic activity through urobilin and uroplasmin activator. It has a vascular function and is a carrier of inflammation. Therefore, circulating microparticles derived from red cells, platelets, endothelial cells, and monocytes may contribute to hypercoagulative state in hemolytic anemia. Microparticles expose histolized serine and the membrane and stimulate thrombin generation. The aim of our present work is to clarify the presence of erythrocyte-derived circulating microparticles in sickle cell disease patients during painful crisis and in steady state compared to healthy controls. Also to study the impact of these microparticles on coagulation activation and fibrinolysis through D-dimer measurement as a marker of coagulation activation. Our study included 36 normal controls and 25 sickle cell patients were studied twice, once during the painful crisis and another time during their steady state. A painful crisis was defined as seeking medical treatment for not otherwise explained pain in extremities, back, abdomen, chest, or head, while a steady state was defined as a period without pain or painful crisis for at least 4 weeks. The most common precipitating factor for painful crisis was infection and fever in 60% of the patients, exposure to cold in 36%, and infection and dehydration in only 4% of the patients. The patients are classified according to the frequency of painful attacks into 3 groups, whether they are having high frequency, low frequency, or moderate frequency of painful attacks. And this frequency was determined according to the number of attacks per year. Low frequency, the patient has less than 1 attack per year. A moderate frequency from 1 to 5 attacks, and high frequency more than 5 attacks per year. 44% of the patients presented with moderate frequency, 40% with high frequency, and 16% with low frequency of recurrence. According to the patient genotypes, 60% of the patients had sickle thalassemia disease, 36% had homozygous hemoglobin S disease, and 4% had hemoglobin S disease. The sample collection was as follows. 2 milliliters unit blood was taken from the anti-clinical bin without tourniquet. We didn't use tourniquet in order not to stress the cells and stimulate the release of microparticles. And blood was collected on sodium citrate. Within 15 minutes after collection, cells were removed by centrifugation at low speed to prevent platelet destruction and the release of platelet-derived microparticles. And this platelet-poor plasma was free of leukocytes, erythrocytes, and contains only about 1% of the original number of platelets. Plasma was added into small aliquots, each containing 25 microliters, and were immediately stored at -80 degrees centigrade until further investigation. These plasma aliquots were used for detection of erythrocyte-derived microparticles by flow cytometry and are used for D-dimer estimation using semi-quantitative assay. For detection of microparticles by flow, they were prepared as follows. 5 microliters of suspension are added to 35 microliters calcium chloride, and 5 microliters annexin 5, 10 microliters glycoprotein A monoclonal antibody, and the total volume was 55 microliters. They were incubated in the jar for 15 minutes at room temperature, and then 100 microliters calcium chloride were added. After that, they were analyzed on flow cytometry. Okay. The microparticles are these small populations, and they are calculated the number of microparticles per milliliter according to this equation. Microparticles were higher in the patients compared to the controls, and the statistical significant difference was found only between patients in the ventral crisis and controls. A result of design were as follows. Design in sickle cell patients during crisis and the disease state in compared to normal controls is high. There was a positive correlation between the level of microparticles in crisis and design level in crisis, but not in the steady state. As regards the impact of erythrocyte-derived microparticles on coagulation activation during painful crisis, there was a borderline inverse correlation between number of microparticles and activated disease. In conclusion, sickle cell disease is associated with increased level of circulating microparticles and elevated D-dimer level, which may contribute to the hypercoagulable state and the precipitation of painful crisis in sickle cell disease patients. I would like to thank my colleagues in this work, Professor Mona Gamrawi, Dr. Hanal Hosseini, and Mahesh, and thank you for your attention.
Thank you very much, Joanna, for this very impressive really study. We are running out of time, so I'm going to close the session. Thanks for all the speakers and thanks for the audience, and thank you very much. Dr. Magdi, Dr. Bad, please come.
First of all, before I start speaking, I want to thank the organisers very, very much for the kind invitation to come back to Egypt again. may not know, but the winter in Britain went on for 6 weeks longer than usual, and there's hardly any leaves on the trees where I live at the moment, so Manchester were knocked down and put into the one children's unit, and it's now one of the biggest children's hospitals in Europe, and we're very lucky to have really fantastic facilities. My old hospital was so old that Florence Nightingale actually wrote a letter after the Crimean War to say what a nice hospital it was. So it is nice to be somewhere that's actually built for the 21st century. Play football in Manchester or Madrid or Munich or Milan or Cairo, you're going to have a different style of play, but it doesn't mean you're not going to win the game. So, this is my lovely new hospital, and that's my office there, second floor. The only one I think with a light on. Everyone else has gone home now. So, I'm going to talk about, first of all, who we transfuse, the problems that there are of regular transfusions. We've heard a lot about them today, so I'll only talk about those briefly. And how we sort of approach the management to long-term transfusions with our knowledge about what the problems are. Now, at the moment, most of our patients have thalassemia major. Most of our patients have thalassemia major. Increasing numbers of patients are being transfused long-term because of sickle cell disease. And I think over the next 2 years that's going to completely change. And that sickle cell disease will be by far the dominant reason for doing long-term blood transfusions because of primary stroke prevention, we heard from Professor Adekele today. And as I say, at the moment, about 60% of our patients have thalassemia major, 35 sickle cell disease, but that will change and has already changed. There are another 5 or 6 patients just from last month waiting to start regular transfusions for stroke prevention. And we have a small number of patients with diamond black thalassemia. Now this is a difficult condition to treat, and a lot of the patients have other family members, sometimes parents, who have been affected, and they are supposedly steroid responsive patients. But if you look at the parents, one lady in particular is about 4'6", and for a UK that's extremely small. And so I think now that we have better collation, more and more we're going over onto regular transfusion for these patients rather than to give them high-dose steroids that we know in the long term is going to have major effects on growth. And to avoid any of the initial effects on growth, none of the patients are transfused until they're about 18 months old. So this is the real change that there has been over the last 3 or 4 years. And this is the stroke prevention for patients with sickle cell disease. Now, we know that stroke is sickle cell disease is the commonest cause of stroke in childhood. And these can be really devastating. Although 2/3 of the patients make a good physical recovery, I think what's even more upsetting for families is that these patients often change their personalities. Instead of being clever at school, they do very badly. Instead of being passive and nice, they become aggressive. And I certainly know at least 2 patients whose lives have been completely ruined by the neurocognitive defects that happen after stroke. But we know that once you've had a stroke, regular blood transfusions are very good at preventing recurrence. And then it was found using transcranial Dopplers it was possible to predict the patients at risk of stroke. And this has really been a terrific boon, I think, to the patients with sickle cell disease. I won't go through this because Professor Adekele mentioned it this morning, but there's no doubt at all from the STOP1 study, follow up the STOP2 study, there's a very good way to preventing strokes. But of course they're not 100%, and this time last year one of my patients came up to clinic and actually started having a focal seizure while he was in with me. And we did a quick exchange transfusion, got scans and MRAs done, and he passed his transcranial Doppler 3 or 4 months before. But what we found was that he had enormous numbers of collateral arteries that were actually making up the flow. so that's why we haven't detected him on TCD. We also found that his left hemisphere was extremely shrunken from a very poor blood supply to it. So the neurosurgeons put his meningeal artery inside his left hemisphere, and over the last year the left hemisphere has been gradually getting bigger. And he's going to have a bone marrow transplant in 2 or 3 months' time. So TCD doesn't always happen, but that's the only stroke that we've had in the last 3 years since we started introducing it. I just want to talk a little bit about transfusion safety. Now, curiously, Dr. Shah also mentioned what was going on in Germany in the 16th century. And I think what worries me most about this etching is that this etching is not just an etching of something peculiar that nobody should ever do, but it's actually an advert for the different kinds of catheters that can be used to get the wrong blood into the wrong patient for the wrong reason. And I hope that what we're doing now isn't going to seem in 300 or 400 years' time as something completely insane. I'm sure it's not. One of the big problems to deal with, first of all, are transfusion errors. Now, we're very lucky in the United Kingdom because for the last almost 14 years now, every single transfusion error or transfusion problem has been the details of it's been sent into what we call SHOT, the Serious Hazards of Transfusion Department, and it's given us a fantastic insight into things that actually go wrong with blood transfusions. And one of the simplest things that we can start approaching, or already well into approaching, the difficulty of transfusion errors. And 95% of these errors of misidentification are very simply addressed by just getting whoever's taken the blood to read the wristband of the patient it's come from, and the person who's putting the blood up to make sure they also read the wristband of the patient that it's going into. And so these very simple things can make very large differences to the safety of giving blood transfusions. And we're banging it into junior doctors and nurses that if you're taking blood from an inpatient, you mustn't wipe the bottles out beforehand, and you must do it at the patient's bedside when you've identified the patient. We did a sort of 10-year summary from SHOT about what actually happens in the United Kingdom to blood transfusions that have errors. And there were 4,335 errors, but that was out of 32 million units of blood and blood product that have been given. And most of them here are actually people being given blood that wasn't CMV tested when it should have been. And these are all going to disappear now because we've decided that CMV testing is a waste of time and should only be used for patients under the age of 1. So even if you've got a bone marrow transplant, even if you've got severe combined immunodeficiency, if you're over 1, we're not going to bother giving CMV negative blood products anymore. But I think the most astounding thing that worries the patients most is that out of those 4,335 errors, there were only around 60 that were related to infections. If we look at what these are, more than half of them were bacterial. And rather surprisingly, we had more deaths in the United Kingdom during that 10-year period from malaria patients having blood transfusions than from viruses. The bacteria generally from patient skin, the donor skin not being properly cleaned prior to the blood being taken. And sometimes when we're also a bit short of blood in Britain, and when there's a bank holiday or something like that, or the weather's been bad, we also ask our donors to come in and donate. And they're so sort of public-spirited that they come in even when they're not feeling very well. And sometimes we find diarrheal bugs and things like that growing in patients. Now most of these are related to platelets, because platelets are obviously kept at room temperature. But 8 of them were related to blood that had been kept in the fridge. And 3 of those patients died. So we do make it very clear that if you're going to give a blood transfusion, it should be done within 4 hours of being taken out of the fridge. And when we looked at the viruses, as you might expect, hepatitis B, A and B were made up almost 2/3 of the problems. So all our patients are immunised against hepatitis A and B now, so that they can't get those. very low levels of other infections in the donor population. But then, of course, just as we're patting ourselves on the back for that, my other brother Bobby and his colleague Dr. Ironside, who were monitoring ordinary CJD in Britain, found 2 cases in 1995 that really worried them. They'd set up the CJD surveillance unit to find out whether bovine spongiform encephalopathy that had got into the food chain was actually going to affect humans. And they picked it up very, very quickly. I would say that not my brother or Professor Ironside said that 750,000 people would be dead by 2000. The Department of Health did, and as usual, they got the sums a bit wrong. And in fact, in the total outbreak, there's only been 174 people who have been affected. Rather strangely, more than 37 of those patients were blood donors, which is a huge percentage. But it did mean that a lot of potentially infected blood products got into haemophilia concentrates and were actually transfused into patients. But having gone beyond 2008, there were 3 cases after 2008, all secondary from people who had blood transfusions. But there haven't been any at all for the last 2 years. So it looks as though the epidemic is over.
Pediatric genetic department. This is quite a routine, but